Hello, everyone. Welcome back to another episode of PodBites, where we break down complex medical topics into bite-sized pieces, perfect for your commute, coffee break, or whenever curiosity calls. I'm Jana Khalifa, and today we're diving deep into the liver. Not just skimming the surface, but really going to battle, looking at how we fight viral hepatitis at the molecular level and how we manage the heavyweight end-stage consequence, liver cirrhosis. I'm joined by my co-host, Sabin Fadlalla. Ready to save some liver, Sabin?
Hi, Jenna. Oh, I'm more than ready. We're talking about everything from the alphabet soup of hepatitis B and C to the complications of cirrhosis, like ascites and encephalopathy. It sounds like a lot, but we're going to keep it simple and high yield.
Perfect. Let's set the stage. Viral hepatitis is inflammation of the liver caused by viral infection, and it's actually one of the leading causes of liver cancer and liver transplantation worldwide. There are several hepatitis viruses, from A to E, but today we're focusing on hepatitis B and C because these are the ones that love to stick around and cause chronic disease.
That's right. Acute infections often resolve on their own, but chronic infection is where the real danger lives. For hepatitis B, chronic disease is defined by the persistence of the surface antigen, HBsAg, for more than 6 months. That's when the risk of cirrhosis and hepatocellular carcinoma skyrockets.
Okay, let's start with a scenario. A patient walks in with chronic hepatitis B, active viral replication, and rising liver enzymes. The goal? Prevent fibrosis, cirrhosis, and cancer. So, Sabine, what's in our treatment arsenal?
So for hepatitis B, we've got two main therapeutic strategies. First, we have the Pegylated Interferon alpha, which revs up the immune system. Second, there's the oral nucleoside or nucleotide analogues, which directly shut down viral replication. Think of interferon as a loud immune alarm and the analogues as precise viral jamming devices.
Ooh, let's start with that immune alarm. Pegylated interferon alpha. Why pegylated?
Great question. Pegylation just means we've attached a polyethylene glycol chain to the drug. This makes the molecule bigger, so it stays in the body longer and it absorbs slower. It basically extends the drug's half-life so the patient doesn't need as many injections.
And how does it actually fight the virus?
Well, it activates intercellular signaling pathways like the JAK-STAT pathway, leading to production of antiviral proteins. At the same time, it boosts our immune security guards, which are the natural killer cells, the cytotoxic lymphocytes, and macrophages, which will enhance viral clearance and inhibit replication inside the infected hepatocytes.
But it's not all sunshine and rainbows. Interferon has a lot of side effects, right?
Not at all. It's notorious for having minimal side effects resembling a bad flu. So pretty much fever, chills, fatigue, and myalgias. More seriously though, it can cause depression, bone marrow suppression, and even cardiac issues. That's why interferon is contraindicated in patients with psychiatric illness, autoimmune diseases, pregnancy, uncontrolled seizures, or decompensated cirrhosis.
Oh! Let's talk about the viral jammers, the nucleoside and nucleotide analogues. Let's zoom in on one of the heavy hitters in hepatitis B treatment, Tenofovir. This one shows up everywhere.
And that's for good reason. Tenofovir is a nucleotide analog of adenosine monophosphate, and it's one of the preferred first-line drugs for chronic hepatitis B.
Walk us through how it works.
Tenofovir is taken orally as a prodrug. Once it's absorbed, it's converted into its active form and phosphorylated inside the cell. From there, it competes with the normal DNA building blocks during the viral DNA synthesis. When HBV polymerase grabs tenofovir and tries to extend the DNA chain, then bam! Chain termination. No complete DNA, no replication.
So it's precise, effective, and long-acting? That's why we love it so much. Okay, Subi, do you have anything else to add about Tenofovir?
Well, she really is that girl. Tenofovir has high antiviral potency, a very low rate of resistance, and it works well even in patients with high viral loads. It's also one of the preferred agents in pregnancy, especially to prevent mother-to-child transmission of hepatitis B.
Nothing's perfect, though. What should we be watching out for?
The biggest concern is nephrotoxicity, so renal function needs to be monitored. Long-term use can also affect bone mineral density. More common side effects include nausea, headache, diarrhea, fatigue, and rash. Rare but serious side effects include lactic acidosis and hepatomegaly.
So, if you had to summarize Tenofovir in one line?
Potent, reliable, low resistance. But always keep an eye out on the kidneys and bones.
Alright, we talked about Tenofovir, but it's definitely not alone in the HBV lineup. Let's zoom in on 3 other oral antivirals you might hear about: lamivudine, adofovir, and entecavir.
Think of these as different generations of the same idea. tricking the virus into sabotaging its own DNA replication.
Let's start with the OG, lamivudine. I feel like this one sounds familiar.
It should. Lamivudine is a cytidine nucleoside analog, and we also use it in HIV therapy. Inside the cell, it gets phosphorylated into its active form and then it sneaks into the viral DNA. Once it's incorporated, chain termination happens and viral replication stops.
Sounds solid. So why don't we use it first line anymore?
Resistance, and lots of it. Lamivudine works well at first, but HBV develops resistance quickly due to viral mutations. That's why it's no longer preferred for long-term management, even though it's well tolerated and has good oral bioavailability.
Alright, next up, Entecavir. How is this one different?
Adafovir is a nucleotide analog of adenosine monophosphate. Once phosphorylated, it gets incorporated into viral DNA, and just like lamivudine causes chain termination by inhibiting HBV DNA polymerase.
So what's its claim to fame?
Compared to lamivudine, resistance develops much more slowly, which was a big win when it was introduced. But there's a trade-off.
Uh-oh.
Nephrotoxicity. That's the major limiting side effect and the reason Entecavir isn't a go-to first-line drug anymore.
Alright, saving the best for last, Entecavir.
Absolutely. Entecavir is a deoxyguanosine nucleoside analog and one of our preferred first-line agents for chronic hepatitis B.
What makes it stand out?
It's powerful and precise. Entecavir inhibits multiple steps of the HBV replication process: reverse transcription, DNA synthesis, and transcription. It has high antiviral potency, a low resistance rate, and it's taken orally once daily.
Any side effects we should remember?
Mostly mild ones: headache, nausea, and sometimes increased blood glucose or reduced kidney function. Rare but serious side effects include lactic acidosis and hepatomegaly, especially in patients with advanced liver disease.
Alright, quick question for the listeners. Which drug works by activating the JAK-STAT pathway and is contraindicated in pregnancy?
That's Pegylated Interferon alpha. Remember, the flu-like side effects.
Now, let's shift gears to hepatitis C. Unlike hepatitis B, this is a single-stranded RNA virus. And here's the key difference. Acute HCV infections should be treated to prevent chronic disease.
And this is where modern medicine really shines. We use direct-acting antivirals, or DAAs, that target specific proteins in the HCV life cycle.
Alright, before we move fully into the newer direct-acting antivirals, we need to talk about an older but important player, ribavirin.
Ribavirin is a guanosine nucleoside analog, and historically it was a cornerstone of hepatitis C treatment, especially when combined with interferon.
So how does ribavirin actually work? Because it feels a little mysterious.
You're not wrong. Ribavirin has multiple mechanisms. First, it directly inhibits the HCV RNA-dependent RNA polymerase, interfering with viral RNA synthesis. Second, it increases the viral mutation rate, pushing the virus into what we call error catastrophe. And third, it enhances the host immune response against the virus.
Oh, triple threat.
Exactly. But here's the key clinical pearl. Ribavirin is never used alone. It's always part of combination therapy, either with interferon or with direct-acting antivirals.
Alright, so what's the catch?
The side effects. The most notorious one is hemolytic anemia, which can be dose-limiting. Patients may also experience fatigue, cough, rash, and irritability.
And this one has a big red flag, right?
Massive red flag. It's highly teratogenic, so both female patients and male partners need strict contraception during treatment and for months afterwards.
So where does ribavirin fit today in the era of DAAs?
It's used much less now, but it still shows up in select cases, like difficult-to-treat genotypes, prior treatment failure, or advanced liver disease. Always as an add-on, never solo.
So ribavirin, guanosine analog, combo therapy only, hemolytic anemia, and a hard no in pregnancy. Now back to the DAAs. Hit us with an analogy.
All right. Imagine the virus as a construction site. We shut down the supervisors with protease inhibitors, the architects with NS5A inhibitors, and the builders with polymerase inhibitors.
I love it. What about the protease inhibitors?
They all end in previr, like glycaprevir or peritapravir. They block the NS3 NS4A protease, which normally cuts a long viral polyprotein into functional pieces. No cutting means no working virus. Remember, previr equals protease inhibitor.
Adverse effects include an itchy rash, nausea, fatigue, and anemia. Youch. Now the asvir drugs.
Those are the NS5A inhibitors like ledipasvir, piprentosvir, elpasvir, and asvir, all ending in asvir, and they all inhibit NS5A. They block formation of the membranous web, which is essential for viral RNA replication and assembly. Fun fact, and this one shows up in exams, ledipasvir needs an acidic stomach, so proton pump inhibitors, H2 blockers, and antacids can reduce absorption.
And finally, the uvirs.
These are NS5B polymerase inhibitors like sofosbuvir and dasabuvir. Remember, those ending in uvir are nucleotide analogues. They directly block RNA synthesis. Sofosbuvir, for instance, is a nucleotide analog that is highly potent, well-tolerated, and one of the backbone drugs of modern HCV therapy.
Let's do a quick question. A 32-year-old woman who is a known case of hepatitis B virus was on Pegylated Interferon alpha 2A. After finding out that she is now pregnant, she visits her doctor inquiring about whether the drug she is on is safe for her baby. Her physician switches her drug. Which of the following drugs does she switch her to? Is it A. Tenofovir, B. Adofovir, C. Entecavir, or D. Telbivudine?
That's got to be Tenofovir. It is the only one safe for pregnant women.
Now, when chronic damage wins, we end up with cirrhosis. This is the late stage of liver disease, marked by diffuse fibrosis, distorted architecture, and regenerative nodules. Usually, we begin by treating the underlying condition: antivirals for HCV, lifestyle changes to reduce hepatotoxic things like liquor. Alright, before we dive deeper into managing complications, I want to pause for a second. Because for a long time, cirrhosis felt like a point of no return. But now, we actually have a drug that targets the disease process itself. Enter resmetirom.
Yep. Resmetirom is kind of a big deal. It's the first FDA-approved drug with anti-fibrotic effects in chronic liver disease, specifically approved for non-cirrhotic NASH or MASH with moderate to advanced fibrosis alongside diet and exercise.
So this isn't about treating ascites or encephalopathy. This is about changing what's happening inside the liver.
Exactly. Resmetirom is a selective thyroid hormone receptor beta agonist, or THR beta agonist. Think of it as a T3 mimic, but a very targeted one.
Targeted how?
Well, thyroid hormone receptors come in two main types, alpha and beta. Alpha receptors are mainly in the heart and bone, so stimulating them can cause unwanted side effects. Resmetirom selectively activates the thyroid hormone receptor beta, which is the dominant receptor in the liver. That means it boosts hepatic fat metabolism, reduces liver fat, decreases inflammation, and slows fibrosis without overstimulating the heart.
So it's not reversing end-stage cirrhosis, but it's slowing the slide.
Exactly. It's important to be clear here. Resmetirom is not approved for advanced decompensated cirrhosis. It's for patients earlier in the disease spectrum, where fibrosis is still potentially modifiable.
That actually feels hopeful.
It is. This drug represents a shift from purely managing complications to targeting the underlying pathophysiology of chronic liver disease.
So if we had to summarize resmetirom in one line,
it is a liver-selective thyroid hormone mimetic that improves fat metabolism and slows fibrosis, a rare example of disease-modifying therapy in chronic liver disease.
Whoa, that's pretty cool. Modern medicine truly amazes me. Let's go back to discussing the distortion that leads to portal hypertension, because blood simply can't flow through the scarred liver properly. So how do we treat portal hypertension?
Well, Jay, the first-line drug for that would be the non-selective beta blockers, like propranolol, nadolol, or carvedilol. They lower cardiac output via beta-1 blockade and cause plaque vasoconstriction via beta-2 blockade. This will reduce the portal blood flow and prevent esophageal variceal bleeding. These are dilated, fragile veins in the esophagus formed when blood is forced to reroute around a scarred liver. And when they rupture, that's life-threatening upper GI bleeding.
So this is not a wait-and-see situation.
Not at all. Acute variceal hemorrhage is a medical emergency. Management starts with resuscitation and stabilization. But pharmacologically, we move fast with vasoactive drugs.
Which drugs are we reaching for?
First-line agents are octreotide or terlipressin, Octreotide is a somatostatin analog. It inhibits the release of vasodilatory hormones, leading to splanchnic vasoconstriction, which reduces portal blood flow and portal pressure.
So less pressure, less bleeding, correct?
Exactly! Terlipressin works similarly. It's a vasopressin analog that causes powerful splanchnic vasoconstriction, and it helps control active bleeding.
Okay, bleeding is controlled. Are we done?
Not even close, Jay. Every patient with acute variceal bleeding needs antibiotic prophylaxis. Cirrhotic patients are highly susceptible to infections, especially spontaneous bacterial peritonitis, and infection massively increases mortality.
What else are we correcting, Sab?
Electrolytes and vitamins. Give vitamin K if the patient has coagulopathy, and thiamine in patients with alcohol use disorder to prevent Wernicke's encephalopathy.
All right, crisis managed. How do we stop this from happening again?
Well, this is where the non-selective beta blockers come back into the picture. Drugs like propranolol, nadolol, or carvedilol are used for primary and secondary prophylaxis. They lower portal pressure by decreasing cardiac output, and they cause splanchnic vasoconstriction.
So beta blockers aren't just for blood pressure. They're literally preventing catastrophic bleeds.
Exactly! In cirrhosis, they're life-saving drugs.
Wait! What if the patient's belly starts swelling with fluid? That's ascites.
While for ascites, which is driven by portal hypertension and secondary hyperaldosteronism, treatment starts with salt restriction, then diuretics. The classic combo is spironolactone, which blocks aldosterone, and furosemide. We often use them in a 5:2 ratio to keep potassium levels balanced.
And what about the brain fog or confusion? Hepatic encephalopathy?
Well, that's caused by accumulation of ammonia due to impaired detoxification. First-line therapy is lactulose. It acidifies the colon, converting ammonia into ammonium, which gets trapped and excreted. We titrate it to 2 to 4 soft stools per day.
And if that's not enough?
Then that's when we add rifaximin, a non-absorbable antibiotic that reduces ammonia-producing gut bacteria. It's especially useful for preventing recurrent episodes.
Ding dong, it's the question train. What is the benefit of using lactulose in a patient with hepatic encephalopathy? Is it A, increases ammonia production, B, enhances protein metabolism, C, decreases ammonia absorption, or D, improves liver enzyme function?
Well, I believe the answer for that, Jay, would be C, decreasing ammonia absorption. Remember, if that is not doing it, then we add rifaximin.
Time for the quick-fire recap. Sabin, hit the highlights.
Alright, so for Hep B, interferon for immune activation, Tenofovir, Entecavir for viral DNA termination. Hep C, remember the previrs, the asvirs, and the uvirs. Cirrhosis, beta blockers for portal hypertension, diuretics for ascites, lactulose and rifaximin for encephalopathy.
Beautifully done. From viral replication to end-stage complications, we've covered it all. Thanks for joining me, Sab.
Always a pleasure, Jay. See you next time on PodBites. Stay curious, keep learning, and eat a pear.